everyone, and welcome to this ACP Problem Solving Oncology webinar series. My name is Dr. Anna Olsson-Brown, and I'm a member of the ACP Trainings Committee and just stepping into a consultant post in the Clatterbridge Cancer Centre in melanoma. I'll be chairing this evening's session and talking to you later on after Dr. Shaw's presentation. This evening's webinar will provide you with an overview of the management of malignant melanoma, as well as covering rarer melanomas such as uveal melanoma. The educational content for this evening's meeting is entirely non-promotional, but we are proud to have the webinar series sponsored by Pfizer, world-renowned leader in oncology pharmaceuticals. So this is a great pleasure that I'll introduce our first speaker. Dr. Heather Shaw is a consultant medical oncologist at UCL and Mount Vernon, who specialises in the care of melanoma and other skin cancers. This evening, she'll be providing us with an overview of the management of malignant melanoma, both in the adjuvant and metastatic settings. Her talk is pre-recorded, so we're going to go ahead and listen to her presentation now.
Good evening and welcome to this Association of Cancer Physicians webinar. This evening's topic is melanoma, and I've been asked to talk about the treatment of malignant melanoma, and we'll do that with regard to both a metastatic and an adjuvant setting. So we've got a brief overview here, give you a little reminder of what melanoma is, how it looks, and what you're thinking about when you see it. And then we'll talk both about metastatic melanoma and adjuvant melanoma therapy strategies. So melanoma is the 5th most common cancer in the UK for both males and females. And the most up-to-date data point that the CRUK epidemiology database holds is still 2017. So I'd imagine actually it may have gone up further when we get the new data out. About 16,000 new cases per year, males and females equally affected, and a rising incidence year on year since the early 1990s, and approximately 135% increase in cases. Melanoma accounts for 4% of all cancers, so not that many actually, although it's the 5th most common cancer, but 1% of all cancer deaths, certainly on historic data. So that's a significant mortality burden for a relatively rare cancer, in fact. 88% of affected individuals will survive more than 10 years, and that's actually due to the fact that the majority of cases are diagnosed at early stages where the risk of metastasis and distant recurrence is lower. 91% of cases are diagnosed at stage 1 to 2, and that will be the vast majority of cases who do well. Perversely, however, this early stage melanomas provide most of the metastatic cases simply due to numbers, although the likelihood of any one patient with stage 1 to 2 disease becoming a stage 3 or 4 disease patient later is actually relatively low. So here's the famous melanoma list of characteristics. So we have asymmetry, irregular border, changes or heterogeneity in colour, enlarging diameter, and elevation. You'll also know about the symptoms that may be associated with it, with bleeding, crusting, itching, and sometimes the appearance of microsatellites around the primary lesion in some patients if they present late. I'll also caution at this point to be aware of the amelanotic melanoma. So the picture on the far right of your frame there is showing an amelanotic melanoma. So bear in mind that not all melanomas are dark or pigmented, and certainly in skin of patients with colour, they may be also quite difficult to determine, so you may require some specialist input, and don't be frightened to ask your dermatology colleagues for help if you are uncertain about a lesion. So melanoma therapy's come a really long way. I first started treating melanoma about 10 years ago, and at that point in time there really wasn't very much. And so their options at that point were dacarbazine, so chemotherapy, a clinical trial, surgical resection if the disease was limited and you would try to reduce the disease burden or render the patient disease-free if that was possible. You would see patients with multiple in-transit lesions up one limb who'd have had 80 or 90 small resections of lesions on their limb, and that was clearly, you know, a really unhelpful strategy, but the only one that was available for some patients. Sometimes irradiation of problematic lesions would be offered up for bleeding or pain or ulceration, and that still happens. or isolated limb perfusion or infusion, where the vessels of the affected limb within transit disease are isolated and high-dose chemotherapy filtered through that limb and then filtered off before it comes to the rest of the body, so that you don't have the systemic toxicity of the high-dose treatment. Tricky, challenging, and done only by very particular surgical centres, and a relatively complex side effect rate, as you can imagine, with such an intervention. Interferon or IL-2, which were early immune therapies and still available and still used in some settings now, although by the time I started treating were fairly much out of favour due to the very significant side effects they can induce, particularly with IL-2, which can end up sending patients to ITU with renal impairment and so on. Best supportive care was always there, and it did feel at some points like you might have been a palliative care physician after you'd been through perhaps one line of treatment in a clinical trial, if you had that available to you. It was effectively a diagnosis that had a very poor outcome and ended in fairly spectacularly bad fashion for the majority of patients. This is what we have now. So that list is longer. I've left the ones that were there already because they're still there and they still exist, although I have taken out the interferon and the IL-2 because they're not used in the UK really at the moment in a standard of care setting for melanoma, although they are used in some settings in parts of clinical trials. So here, clinical trials are now wide and varied and looking at post-immune therapy progression. We also have cell therapy available for melanoma, and some of you may have seen some of the data on that that's been presented at oncology meetings relatively recently, and it looks like a very exciting forward therapy going into the future, although it's complicated and quite centre specialised to give. We still have irradiation, we still have isolated limb perfusion and infusion, although again, the rate of that has fallen since some of the agents further down the list have become available. We have checkpoint inhibition immunotherapy, which everybody is aware of, and the mainstay of its development actually came in melanoma. Targeted agents, which work in molecular abnormalities in the tumour. In the case of melanoma, that's BRAF mutation status. And we also have TVEC, which is a modulated intratumoral viral agent where you inject the drug straight into the skin lesions and they induce an immune response in the local region to help clear that tumour. And quite often TVEC or single agent immunotherapy are now used instead of the aforementioned isolated limb perfusion and infusion, because they tend to have a much lower rate of complications and good disease control. There's also a modality described as electrochemotherapy, which again is usually performed by surgeons, where you inject chemotherapy into a lesion and then you induce an electric current through that lesion to permeate the cancer cells with the chemotherapy. It's again specialised and not used very frequently, except in situations where you feel that local control is important, because obviously it's not used for deeper lesions. So here's the evolution of melanoma therapy over time. And you'll see we've gone all the way back to pre-1960s, where the black cancer was always managed surgically and cut out. Then coming into the 60s and 70s was the evolution of dacarbazine. And so although we still use it in very selected patients, it's pretty elderly now. I'll caution that I came around that time too. High-dose interferon and IL-2 are also mentioned there, but as I've said, they've somewhat fallen to the wayside and less combined in clinical trials. Then looking at the last decade, we have run at the range of things that we have for melanoma now. Ipilimumab, which is an anti-CTLA-4 antibody, came in 2011, followed very swiftly by the first of the BRAF inhibitors called vemurafenib, then single-agent dabrafenib. Then in 2015, we had a deluge of agents with nivolumab and pembrolizumab, which were single-agent anti-PD-1 therapies. TVEC, which is the injected intratumoral modulated virus therapy that we've just discussed. Cobimetinib and vemurafenib are a combination of BRAF and MEK inhibition made by a particular drug company, and dabrafenib and trametinib are an alternate selection. Cobimetinib and vemurafenib as a combination are not licensed in the UK and not used in general. Dabrafenib and trametinib are. Nivolumab and ipilimumab, a combination immunotherapy of the two single agents that we've just mentioned. And binimetinib and encorafenib are yet another combination of MEK and BRAF inhibitors together. Anything in blue is intended for BRAF mutated melanoma only. Anything in orange could be used for either mutant or wild type disease. So if we go to everybody's favorite fashionable friend, immunotherapy, and ask why would we use it? The vast majority of treatment options in advanced cancer are very limited. You'll be aware of any cancer patients that you might have treated in clinics such as GI oncology, ovary cancer, breast oncology, that you get periods of disease control to the agent you're applying, followed by the cancer's ability to generate resistance and then become insensitive to the treatment. And therefore you get progression of disease, you switch agent and you start the cycle again. With immune therapy, there's a potential durability of control. The immune system potentially has multiple and actually limitless targets when you think about it. You're alive today because your immune system has combated something different every single day since you were born. And so therefore you can potentially teach it to recognize anything if it can see the correct antigen. The evolution of the immune response has the potential to keep up with the evolution of resistance in the tumor that we've just discussed. And therefore, if you can teach the immune system to see the tumor, it may well be able to see it in perpetuity going forward, and you end up with disease control for life, which is obviously what we would like. So the immune system works in two phases. We describe it as immune surveillance. So first up, there's a priming phase where the dendritic cell shows the T cell the antigen. And we know that the CTLA-4 type antibodies work in the inhibitory part of this pathway and prevent the inhibition of that signaling. So you turn up the signaling effectively. That's drugs such as ipilimumab. Then you have the effector phase, where the T cell finds the antigen-bearing cancer cell and would induce a destruction response, a kill response. And we know there that the negative regulation is mediated by something in the PD-1, PD-L1 interaction, and that's a sort of recognition of self. Some tumours will overexpress PD-L1 to hide from the immune system, and you can take advantage of that with anti-PD-1 drugs or anti-PD-L1 drugs. So anti-PD-1 drugs in melanoma would be nivolumab and pembrolizumab. The question then becomes, so who should have immunotherapy? And there are some hallmarks of patients who are likely to respond to immunotherapy. In a standard of care setting, it's limited what you know about the tumour. You may know that there were tumour infiltrating lymphocytes in the original biopsy, and we think that that's related to potentially an increased rate of response. We don't tend to look at PD-L1 status in melanoma because we know patients can respond even with no PD-L1 expression. We know that patients who express lots of markers of chronic inflammation, so high LDH and a suppressed immune system, will not respond so well. You know that patients who are under significant strain from the volume of their disease will not respond so well. Patients who require steroids before initiation of immunotherapy for reasons other than simple adrenal replacement also don't do so well because that affects their host response. We know the microbiome can potentially drive some of the immune response and some of the ability of people to respond to immunotherapy. And that's what that little set of cells are at the bottom left-hand corner there. We know that some of the alterations within the tumour will affect the ability to respond. So whether or not they've retained MHC expression, whether there's still interferon signalling, whether the tumour carries epigenetic alterations that makes it different and therefore not recognised by the immune system. We also know that there are some tumours where there's no infiltration and they're described as cold tumours. The cells in the immune system are excluded from the tumour by what the tumour is exuding, and therefore we would not expect an immune response in those patients. And of course, a lot of the research that we're doing and looking at now is trying to work out for those patients where we don't think they will respond with current knowledge, how we might make them respond. How can we turn that cold tumour hot? We're not going to go much more into that today, but it's certainly something to be thinking about. The other thing that we think about when we're talking about melanoma is how unusual it looks to the immune system. So as I've said, we don't need PD-L1 expression for anti-PD-1 therapy to work in melanoma. And that's because melanoma cells carry a very high mutagenic burden. So the cells look very abnormal to the immune system. And you'll see here in this somatic mutations database that melanoma sits far to the end beyond any of the other described cancers. And actually, the only two that sit further out than it are the other skin cancers, which I know Dr. Sacco may well come back to later. So what's currently available and out there? What's going to be in your clinic? So anti-CTLA-4 antibodies are ipilimumab and tremelimumab. Anti-PD-1 are as listed, nivolumab, pembrolizumab, and so there's a whole range of others in development, and anti-PD-L1 are there. The ones in red are the ones that are currently licensed for use in melanoma and in common use in most melanoma cancer clinics. There's a whole slew of other antibodies in development against both activating receptors and inhibitory receptors, along with cofactors and a number of other modulations of the metabolic system and the gut microbiome to see whether or not we can involve some of the tumours which we would otherwise not have a response in. So does it work? Well, this data is pretty old now, it's from 2015, but even at that point, there were 10 years worth of data of ipilimumab from clinical trials. And Dirk Schadendorf, who's a dermato-oncologist in Germany, brought together the data with some colleagues and showed that actually if your body had responded to the ipilimumab and you made it to the 36-month time point, the 3-year time point, it was very likely that you'd maintain that response all the way out to the 10-year point, which is where most of their data follow-up stopped because that was the standard for the studies. So it's quite impressive that if you can mount a response and make it to that point, that response may well be something that carries on forever, or at least a very significantly long time. We then went and looked as the scientific world found another marker, the PD-1, PD-L1, and developed antibodies against it. And so this here was Checkmate 066, which was a study looking at nivolumab, anti-PD-1, against dacarbazine, which was the standard of care at the time in the way of chemotherapy for patients with metastatic melanoma. And you can see here that the blue line is the dacarbazine patients and the orange line is nivolumab. This is a very early time point. This is just a 15-month, 12 to 15-month time point for this study. And you can see already that the patients who've received dacarbazine are having a fairly dismal time, with the patients surviving falling down very, very swiftly on that blue line, whereas the patients receiving nivolumab are already starting to level out that line. It's that famous flattening of the curve that people talk about with immunotherapy. So we have two indications there that we have activity in immunotherapy with melanoma. So if those drugs both work individually, what might they do together? One drug's good, two drugs might be better. So they put them together. And they had the Checkmate 067 study, which was ipilimumab nivolumab versus nivolumab versus ipilimumab. And you can see here that the combination treatment is in the red at top, single agent anti-PD-1 in the form of nivolumab in green and ipilimumab in black. This study was powered to look at nivolumab, ipilimumab versus ipilimumab, not versus nivolumab. However, they always show the nivo data, so you always get to see it. So this is the 6.5-year follow-up data, which was just presented at ASCO in June. This is the overall survival percentage. So you can see here for the dual-treated patients, there's a significant survival benefit to either single-agent PD-1 or in some cases, dual immunotherapy. And so therefore, that really has become the standard of care for melanoma for most patients in clinic. If they are fit enough and well enough, the general feeling is combination immunotherapy will be the current standard offer globally as it is. The safety summary. So immunotherapy has a very wide selection of side effects, and we're not going to go into them here today. But in general, we think about immunotherapy as causing inflammation in an unintentional way. And it can do that in any organ in the body. I usually say to patients that if they can think of an organ and put itis on the end of it, they've pretty much covered the side effect list for immunotherapy. There are various predilections of anti-PD-1 therapy versus anti-CTLA-4 therapy for particular organs, But in actual fact, there are no rules, and any immunotherapy can cause inflammation in any organ at any time during therapy or even after cessation of therapy. So if someone's ever had immune therapy, you need to have your ears and eyes open if they are reporting symptoms. So here's the overall safety summary for the trial. This was from the original paper. And given that even with the continued follow-up, they've seen no new safety signals, I've left this table in here. So you can see that combination immunotherapy is significantly more toxic than single agent immunotherapy of either type, but actually ipilimumab is somewhat more toxic with the discontinuation rate and the grade 3-4 events than nivolumab as a single agent. So we quite often find that when we initiate combination therapy, which is given for 4 cycles at the start of immunotherapy, and then we move to maintenance nivolumab, the patients sometimes struggle to make their way through the 4 cycles of combination immunotherapy. We may have to stop for toxicity. Here it says that 40% for any grade led to discontinuation. I think it's probably what we're really trying to do with immunotherapy is to get the patient into a position where they have maintained control of their disease and do not require ongoing therapy. So the standard length of therapy for immune treatment in most countries is based on study data and some management of health economics. And therefore they would have 4 cycles of ipi-nivo followed by maintenance nivolumab out to a total of 2 years. Nivolumab alone or pembrolizumab alone would be given for 2 years, and ipilimumab was given for 4 cycles and then stopped. So here you can see the CheckMate 067 data showing that those patients who had ipilimumab nivolumab and had their study therapy discontinued either for toxicity or withdrawal of consent or because they had stopped because they reached a time point where that was agreed, that a significant proportion of those patients did not require further intervention. And you can see here that the median treatment-free interval at this point in a 6.5-year follow-up is approaching, this is very significant, 27.6 months there. It's much shorter for each of the single agents. But you can also, if you see in the bottom line here, look at the median duration of treatment. You actually see it's not very long. The median duration of treatment with ipilimumab nivolumab is short, but don't forget that we would only expect people to be treated with dual for a short period of time because of the way it's delivered. But actually, for some patients, it can be a very significant disease management from actually a very small amount of drug. And so therefore, don't be overly worried if you have to stop for side effects, because actually those patients can continue to respond even after cessation. And that can sometimes encourage the patients to tell you when they have problems rather than hide their problems and turn up in extremis with a much bigger issue on board. So here is the overall survival data again. But these are the patients that we are not catching with immunotherapy. So these are the ones where we need new strategies. These are the ones where we need those new antibodies in development, and we need those new things to turn their tumors into something that the immune system can see, or we need new strategies. We've had some combination studies of targeted therapy plus immune therapy, and most did not meet their primary endpoint, unfortunately. We've had a number of agents alongside single agent nivolumab or pembrolizumab in order to try to uplift that missing patient population. TIL therapy, the cell therapy that we referred to earlier, may catch some of that population. But in general, the patients who have less than 3 sites of disease involved, normal LDH, good performance status, the ones where you look at them and you know they're actually okay when they walk into the clinic, are the ones who continue to do well, almost regardless of which treatment you give them. So actually your best judge of whether someone's going to respond or not is very often your clinical judgment as they walk in the door, which means it's a challenge to catch those missing patients. So that's the Keynote 006 data, just so you can see that the pembrolizumab versus ipilimumab study was very similar in the fact that the pembrolizumab chemo as being superior to the ipilimumab as a single agent. And so therefore we think about pembrolizumab and nivolumab relatively interchangeably in the metastatic setting. Nivolumab's dosed every 4 weeks, pembrolizumab every 6 or every 3, depending on which schedule you choose. And it's very much a local choice as to which is used. There are some settings where one has a license over the other, and that's something that you'll pick up as you're sitting in clinic. So what else is there? So we've got targeted therapy. And as most of you will know, melanoma is famous for having a driver mutation in the BRAF gene. So usually V600E is the most common variation of that, but we also see D, G, and K amongst others. And there are other non-V600 mutations that can also be sensitive to BRAF MEK inhibition, and others where they are much less sensitive. So it is important to know which mutation you're addressing when you're picking therapy. Sometimes targeted therapy is more desirable than immunotherapy. Sometimes when you're looking for speed of onset of action, where the patient's deterioration is rapid, where there are imminent threat of their disease due to its location. Symptomatic brain metastases do not do well with immunotherapy. Cord compression is also a challenge because you need to move quickly to save function. Significant poorly controlled autoimmune disease may well be a contraindication to immunotherapy. Failure of prior lines of therapy, so patients who've progressed through immunotherapy and require disease control, BRAF and MEK targeted therapy is a very, very acceptable second-line therapy, in some cases first. Toxicity management, so if they've had adjuvant therapy, and we'll come to that in a moment, and have had very significant immune-mediated side effects with adjuvant immunotherapy, your metastatic first-line treatment may be targeted therapy as choice. Also, patients sometimes have a preference. There are patients who would do anything to avoid infusional therapy. There are patients for whom the side effect profile is unacceptable for immunotherapy. And so there are patients who would elect to have targeted therapy even with a finite duration of control versus immune therapy, which might be an infinite duration of control for a whole host of reasons. So you're sitting in a clinical scenario where you're trying to work out what's the most important thing and to counsel the patient around their choice. So do you want an early and fast response, or do you want long-term benefit? Long-term benefit tends to be associated with immune therapy, but there are a subset of patients who respond to targeted therapy who do very well in the longer term. And again, they tend to be that group of patients with small number of sites affected with disease, low volume disease, normal LDH, and good performance status. And so again, it's that same group of patients who gain the most benefit. Here's the Rasraf MEK signaling pathway. And you can see on the left in normal signaling, there is a route to cell proliferation, survival, and differentiation driven by appropriate pairing of BRAF and CRAF, which then drives the MEK-ERK response for phosphorylation. In the cancer signaling pathway, the BRAF mutation makes it constitutively active, so it's always on. It does not require the extracellular signaling input that's required in a normal pathway. Therefore, you go round all of the requirement for normal signaling on, and it's simply on all the time. Therefore, you get uncontrolled cell proliferation, extended cell survival, and then quite often metastasis. So agents for the Rasraf MEK pathway are usually in combination. Vemurafenib's there on the list. I can't think of a patient that I've seen recently on single agent vemurafenib. It had a significant number of toxicities associated with it, including very severe photosensitivity, and therefore people have tended to move away from vemurafenib as a drug on its own. Vemurafenib and cobimetinib are used in Europe and America in certain settings, but not usually in the UK. Dabrafenib and trametinib and encorafenib and binimetinib are both available in combination. And dabrafenib is also available as a single agent BRAF inhibition if for any reason we don't wish to use MEK inhibition because of toxicity or side effects or comorbidities. Something you might also think about is the primary resistance to melanoma therapy. In some patients where they're deteriorating particularly rapidly, and they have mutant melanoma that would be potentially sensitive to targeted agents, you may only have one chance to treat that patient and to salvage them to go forward. In that case, you may wish to choose a targeted agent over an immune therapy, because as you can see here, the primary resistance to targeted therapy in a previously naive tumour is very low. We are somewhat lacking in data on previously adjuvantly treated tumours, but we would still say, in general, in a patient not exposed to targeted therapy before, you would expect a fairly high rate of response. The published data suggests 85%, and actually in real life, it's probably somewhat higher. So that's simply something to think about when a patient is very rapidly deteriorating in front of you and we need to act now. These are the pooled data from the studies of dabrafenib and trametinib. And this is the 5-year survival data, overall survival. And you can see here that actually there's a relatively good overall survival rate of approximately 35% to 5 years. Do bear in mind that some of these patients will have had subsequent immune therapy, and that will see through the curves. It is, however, interesting to see that the progression-free survival and overall survival, according to the best response to targeted therapy, significantly influences what happens. So you can see here that in both graphs, the complete responders are the green line, partial responders in yellow, and stable disease in grey. And you can see that they're doing significantly better if they have a complete response. So if you have a patient who responds very well, initially you may well find that they sustain that response for far longer than you would otherwise expect. The average duration of control that's quoted is around 9 to 12 months, but these patients can go on for many years actually on targeted therapy as long as they continue. The data of stopping of targeted therapy, even in responders, is poor, and therefore it tends not to be done unless there's a particular reason to cease therapy. So there's a list of side effects here of BRAF and MEK inhibition, and particularly the fevers can be challenging, although there are now new data coming out on how to manage those optimally, particularly with the dabrafenib and trametinib. Encorafenib and binimetinib also have a rate of CK elevation, which needs to be watched for, but all of them have a general set of background side effects, where eye symptoms can be important, as can cardiac left ventricular function in patients with a cardiac history particularly, but would need to be aware of. The majority of these side effects improve really promptly with stoppage of drug, unlike immunotherapy side effects, which can go on and almost always need intervention to manage them. So coming briefly now to adjuvant therapy, and here we have the same drugs simply translated into an adjuvant setting. So this is kind of how cancer medicine evolves, is you have a drug that works in a metastatic setting and you take a step back and say, can we prevent the metastatic disease by using those drugs earlier? So the adjuvant therapy studies involve both targeted therapy and immune therapy. And at the moment, the immune therapy in this setting is simply single agent anti-PD-1. Anti-CTLA-4 in the form of ipilimumab was trialed but never licensed in the UK for use in this setting, so it's not available. So here we're talking about immunotherapy being nivolumab or pembrolizumab, and targeted therapy in this setting being dabrafenib and trametinib, as there is not yet any data to support the use of encorafenib and binimetinib in an adjuvant setting, and it's not licensed per se. So it's a question about whether or not the patient would have adjuvant therapy or not, the benefit, the toxicity, the impact on their day-to-day life when they effectively think of themselves as cancer-free at that point. And also the question also comes, what will it do to their options in the future if their disease recurs despite adjuvant therapy? And we're still not answering that question terribly well with the current data, although more is coming with every conference. So I apologise for the slightly wiggly diagram here, but this is from the AJCC version 8 of melanoma staging. And this is the risk reduction for a patient. So I tend to talk about absolute risk reduction for a patient. So a stage 3A patient to 10 years may have around 10 to 12% chance of recurrence of the disease, whereas a stage 3C patient's got around a 40% chance of recurring. As we'll see shortly, all the interventions can reduce this risk by around 50%. So a reduction of 10% to 5% versus a patient who's going to reduce the risk from 40% to 20% is a very different undertaking when you consider that the side effect profile is identical for both potential risk reductions. So the risk-benefit analysis is going to be different for the stage of the patient. So it's very important that the patient understands what the weighting of their risk reduction may be versus their potential for side effects. So Combi-AD was a study where they took patients with stage 3 resected disease, and at the time it was the AJCC version 7, so it was A through C rather than A through D, which we have for stage 3 now. And the patients were randomized to either placebo or treatment for 12 months. You can see here, this is the 4-year relapse-free survival, that actually the hazard ratio was 0.49, so that's a reduction of risk by 50%, as we've just said. And the overall survival data was in favour of the combination, also with a hazard ratio for death being 0.57 here. Keynote 054 is pembrolizumab versus placebo, and at this study there was an opportunity to cross over to pembrolizumab at recurrence, because at the point of the time of the launch of the study, pembrolizumab was still not freely available. And so here you can see the primary endpoint was recurrence-free survival, and here the hazard ratio is 0.57, so therefore again in favour of drug and reduction of risk of around 50%. You can see here that it's agnostic to BRAF mutation status, so both wild type and mutant patients benefit from pembrolizumab in this setting. Checkmate 238 is a very similar looking study, and this was nivolumab and ipilimumab, but placebo matched to each other. So patients only got nivolumab or ipilimumab. So this was again against an active control of ipilimumab. And you'll see here ipilimumab at 10 milligrams per kilogram, which was the original adjuvant dose of ipi. And so that's a fairly potent dose, as you can imagine, for toxicity in this setting. So this was nivo versus ipi effectively. And you can see here, this is the recurrence-free survival. And the patients, again, the hazard ratio is 0.66. But if you remember here that ipilimumab has a risk reduction of around 10%. If you add that back as the active control, you're again approaching 50% for nivolumab in this setting. And again, you'll see it's agnostic to BRAF status. So at the bottom line is, in an adjuvant setting, in a mutant patient, you have 3 good options, and it will depend on your own preference, the patient's preference, and the toxicity weighting. And the wild-type patients have the choice of anti-PD-1 therapy or not. And again, we think of the two, pembrolizumab and nivolumab, as interchangeable, simply a dosing change that's different. I'd like to thank you all for your attention, for listening, and I hope you continue to enjoy the rest of the webinar. Many thanks.
And so before I go on and present about rarer cancer subtypes, we're just going to answer this question about overall survival. So we've been asked about whether overall survival for patients that have melanoma, whether they get the same survival if they have ongoing immunotherapy, or does it include patients that have had to stop due to toxicity? So it's interesting. So the Series 6-7 data that Heather showed illustrates that people who have both single agent and combination therapy do have this sort of overall survival that tracks of, you know, a good over 50% 5-year overall survival. And actually that is for all comers. So it's for all patients, irrespective of whether they stopped or not. So there are patients who will continue on treatment. There are patients that will have stopped at 2 years due to patient choice or physicianly choice. And there'll also be the patients who had to stop because of toxicity. And interesting, if you look at the median number of cycles that patients received in the 2 arms, the ipilimumab and nivolumab combination arm, and also the arm with just nivolumab on its own, the median number of cycles for patients on the combination arm was actually 4 treatments, and the median number on the nivolumab only arm was 15. And you can see that their survival is comparable, and if anything, according to the data, the ipi-nivo combination arm actually had better overall survival with significantly less immunotherapy given. So it's for everyone. The big question we have is, do we know how many treatments is the optimal number of treatments? And we don't. We don't know how long the duration that we should be giving immunotherapy for is. It is becoming increasingly clear that it's probably actually patient related and not actually the answer is the same for everyone. We do know, if we look at the type of response a patient gets, so if you look at whether they get a stable disease, complete response, partial response, that actually that seems to have a different enduring impact. And patients that have a complete response are likely to need less treatment. So if they achieve that complete response whilst they're on treatment, they're actually likely to need less treatment than somebody who's got a partial response or stable disease. So as we go forward, we need to try and understand that. There are some trials ongoing at the moment to try and understand duration of treatment. There's something called the Dante study, which is stopping treatment at a period of time after starting immunotherapy and comparing that to continuing to progression. Also, interestingly, the melanoma community were in extensive discussions with NICE, because at the moment, the way the NICE approval works for melanoma is you can continue until either there's disease progression or intolerable toxicity, which remains the same, but also now patients are able to stop at 2 years, and you can complete an NHS England form that allows you to stop at 2 years. And then if the patient progresses subsequently on active surveillance, you are then allowed to reintroduce the same immunotherapy again. So it's interesting. So it's changing all the time, but at the moment we aren't sure how long we should be giving immunotherapy for. But certainly the survival data that we have so far is for all patients, all starters, irrespective of whether they had to stop for toxicity or not. Okay. So as we said in the chat, please do carry on posting questions. We can answer them, or certainly we can ask our speakers to look at to look at them and feedback through the ACP website. So I'm going to talk about ocular and mucosal melanoma in just a moment, so hopefully I'll be able to answer that as we go forward. But yes, the short answer is there are differences, and quite considerable differences, between ocular and cutaneous, and we'll talk a little bit more about the reasons for that in a moment. So I'm going to talk a little bit about rarer skin cancers. Unfortunately, Dr. Sacco, who was due to talk to us tonight, isn't able to join us, so I'm going to do it instead. I hope that's okay. So I'm going to take us through different types of skin cancer, and then I'm going to talk a little bit about the different types of melanoma we were talking about. And then we will talk a little bit at the end about some further questions before we go on to the case presentations. So in terms of rare skin cancers, in terms of other skin cancers, actually BCC is the most common type of skin cancer, and the most commonly occurring cancer in the developed world. Interestingly, they generally speaking don't cause very much problems. A lot of patients will come to you with a history of BCC. They arise from abnormal uncontrolled growth of the basal cells. They grow very slowly, mostly are curable, and they cause generally minimal damage when they're caught and treated early. And they're normally surgically managed. We very rarely as oncologists see these patients. They can rarely become locally advanced or metastatic. And when they do that, they sort of develop this creeping type of pattern where they sort of sit under the skin and then creep along various structures, whether that be bone or soft tissue. And so people, generally speaking, get a lot of local symptoms with advanced BCCs. Metastatic BCC does happen. Often you'll get a locally advanced cancer that has then become metastatic, and they are rare, but we do see them. The biggest problem is they cause huge amounts of symptoms, but actually the mortality associated with a long prognosis. There currently aren't any NICE approved options in the setting of locally advanced or metastatic CCC outside of surgery. There was this drug called Vismodujib, which is a hedgehog inhibitor, which is a growth inhibitor essentially, which was initially licensed on the CDF. So it's a licensed drug that you can get privately, but for a while it was available on the CDF. The problem is that it's quite a toxic drug. Patients get very significant nausea and vomiting with it, certainly for the first few months of treatment. So it's actually quite poorly tolerated. And when they looked at the analysis that they used to evaluate following the CDF, whether actually it was the right, whether it was the right decision to make it and put it through for full NICE approval, they used survival benefit as the sort of the metric by which they were determining whether it should be approved or not. And so this actually doesn't really give a survival benefit, largely because of actually this long prognosis that you get with a locally advanced metastatic BCC. But what it does do is it gives pretty good local control. So there are some patients who actually would really benefit from this from a symptomatology perspective, but they don't really see an impact in terms of survival. So it didn't get NICE approval at the time, and so it's actually quite difficult to achieve this. You can apply for things like individualized requests and off-protocol requests, but it's actually very difficult to get this even in compassionate use. So it may be a drug that we see in the future, but at the moment there are no drug therapies for BCC, and again its responsiveness to chemotherapy is unknown, but not fantastic in any strength of the imagination. So really we're quite limited limited in patients that get a locally advanced BCC, and often we resort to clinical trials for all comers if we are going to go down a systemic route at all. We talk about squamous cell carcinoma of the skin. Most commonly occurs in people with white or fair skin. Average age at presentation is between 68 and 73, and they're commonly located on sun-exposed areas such as the head, neck, forearm, and dorsum of the hands. SCC has an increased associated mortality compared to BCC, mostly due to the fact that it's more aggressive and more likely to metastasize. So again, when caught early, they generally speaking are easily manageable. They can occur and look in various different morphologies. So you can get a papule, a plaque, a nodule. They can look pink or red or skin coloured. They can be scaly or exophytic. They can be indurated. And you may get this thing called a cutaneous horn. So they can present in multiple different ways. I think that's their SCCs really, for me, are the main reason for getting skin lesions reviewed by a clinician. Obviously, there's always a concern about melanoma, and Heather shows some really nice pictures of the way that we assess a melanoma, but skin lesions can be SCCs as well, rather than BCC, so it is always worth them getting checked out, particularly if there has been changes to them, and they can be quite friable. They can bleed with minimal trauma, and then they can crust. So some patients will present with this sort of relapsing remitting, they knock them, they bleed, they crust, they knock them, they bleed, they crust, and that often is slightly concerning for us, and something that would definitely be something we consider and want to look into. They are usually asymptomatic. Some people do get itching associated with it, and sometimes the itching can precede the presence of a lesion, but actually most of the time that the symptoms are very minimal. So primary treatment, there are several medical and surgical treatment options. So treatment options, surgical excision, which is normally the standard of care for invasive SCCs. They can have a wide local excision, or they can have micrographic surgery. Non-surgical treatment options for local disease, so they can have radiation therapy for poor surgical candidates, and that is something that's very reasonable and done quite widely. And then there are local treatments such as 5-uracil cream or a Mucosal cream. They're quite nasty, these creams. They can cause quite a lot of local topical toxicity, and so generally speaking, they're typically reserved for in situ SCCs when an excision is a suboptimal choice for whatever reason, and normally due to patient fitness for intervention. For SCCs arising in a sun-exposed skin, the rate of metastases to regional lymph nodes is around 5%, so reasonably high actually. And the likelihood of metastasis is based on some of these elements. So if they're a large or deep lesion, if they're a recurrent lesion, they have a higher risk of metastatic potential. The tumour involvement of the bone or muscle or nerve, something you can't excise or get good surgical clearance. Where they're located does appear to be related to whether they have a metastatic potential, and if they occur in scars or ulcers, other areas of broken skin essentially. Patients who get SCCs as a result of immunosuppression, and that happens very, not very frequently in sort of the grand scale of things, but actually quite a number of immunosuppressed patients will experience SCCs. Again, fine if they're locally present and surgically managed, but some of them can get metastatic SCCs, which obviously causes a bit of a problem, and I'll explain why in a minute. And then tumours caused by arsenic ingestion seems less common and less of a problem nowadays, but there you go, still on the list of things that might make them potentially more of a problem. In terms of the overall rate of metastasis, it's low, but where there are distant metastases are found, the 5-year survival rate is poor at around 25 to 40%. So again, once these lesions become metastatic, they can be problematic and lead to relatively poor prognoses. And in terms of treatment, that has changed quite radically in the last couple of years, and prior to which our main treatment was chemotherapy, and that had a limited response rate. Up to 95% of metastases and local recurrences are detected within 5 years of initial treatment, and actually majority of them occur within the first 2 years post diagnosis of the primary. Advanced and metastatic SCC, relatively rare, tends to metastasize to nodal basins and scalp, but can metastasize anywhere. There is quite a lack of evidence for systemic options for metastatic SCC. Historically, we used to use cisplatin and 5-FU chemotherapy. And we do still use chemotherapy, and quite a lot of the patients that we're still looking after at the moment will have had first-line chemotherapy. Increasingly, we're moving to use cemiplimab, which is an immunotherapy, which I'll talk a little bit more in just a second. It's often quite an elderly population. You saw the average age of onset. So we often have to balance the potential problems with comorbidities. And as I said, the immunosuppressed population quite often get SCCs and have been known to get metastatic SCC. So how we balance the risks of something like immunotherapy and chemotherapy in a patient that's got a transplant or immunosuppressed for any other reason is a real balance, and often is a multidisciplinary approach, thinking about various different elements to it. And are we likely to cause problems with the transplant if it's a transplant patient who's immunosuppressed, who's got a metastatic SCC? How do we manage that? Do they need to be worked at for things like dialysis, so we can treat them in the potential that they may lose their transplant? There are lots of things to think about in the sort of more rare, complicated end of this patient population. Really important to consider quality of life, the efficacy and risk of toxicity for many of our systemic anti-cancer therapies. So the benefits of chemo versus the benefits of immunotherapy. So as I said, we use this drug called cemiplimab, which is an anti-PD-1 immunotherapy agent. And Heather was obviously talking about other anti-PD-1s, so both nivolumab and pembrolizumab are in the same group as cemiplimab. And we see some really quite amazing responses to cemiplimab. So you can see the waterfall plot here shows that majority of people got either got significant responses, actually a very small number getting progressive disease. Interestingly, some patients got progressive disease and then got reduction in their lesions, which is not uncommon for immunotherapy. One of the things we see quite frequently is that you sometimes start treatment, patient's disease will get bigger and then it will start getting smaller. And we used to refer to that as pseudoprogression in all circumstances. Pseudoprogression seems to be a thing in certain malignancies, particularly lung cancer, but in skin cancers, I think our feeling is that it's not really pseudoprogression, it's true progression before you get an immune response, and then you'll get a subsequent response as the immune system starts being able to have a significant effect against the malignant masses. And you can see some of the study outcomes in terms of these are patients that were on trial where they had lots of lesions that have actually resolved. And same here, you can see this patient had a big lesion behind his ear that and then shrunk down really nicely on immunotherapy. So we do see some really good responses to cemiplimab and enduring responses as well. So just moving swiftly on to melanoma. So obviously you've had a nice sort of talk through melanoma and the treatments for it, both in the metastatic and the adjuvant setting. And you can see that in cutaneous melanoma, which is what Heather was essentially focusing on, really there are two groups of drugs: immunotherapies, which are available for all patients with melanoma, and BRAF and MEK targeted therapies, which are available for around 40% of people with cutaneous melanoma. But there are actually a whole other series of melanocyte-associated malignancies which fall under this heading of melanoma, not all of which affect the skin. So the one thing I think is very interesting is there are different mutational changes that are associated with the different melanomas. So in reality, there are cutaneous melanomas, which our major mutation is a BRAF mutation, and then both cutaneous and conjunctival melanomas can harbour this BRAF mutation. So they're the groups of patients that we really want to make sure we've done those BRAF mutation analysis on, so we know what we're looking at. So one of the things that's really interesting about patients with a BRAF mutation is that they also respond better to immunotherapy than those without. So actually understanding a BRAF status tells you a lot about and helps you prognosticate for a patient, both in terms of the possible treatment options, but also the potential that they're going to have of their response to those mutations. But interestingly, there are the other subtypes. So mucosal melanoma makes up about 1% of all melanomas and can occur in any mucosal membrane. The common ones we see are gastric mucosal melanomas and anal and vaginal vulval melanomas. So those present in a very different way. They normally present with active bleeding. So patients normally have to become symptomatic. So they'll either present with a big gastric bleed, a big PR bleed, or a PV bleed. And that's normally how they're detected. Quite often, if they've got an anal melanoma, that they often think they've got hemorrhoids for quite a long time. So it's not uncommon for mucosal melanomas to have a delayed referral, and they often have metastatic or locally advanced disease before they present. Mucosal melanomas don't harbour BRAF mutations very commonly. They do harbour this c-KIT mutation. Interestingly, that always asks and begs the question, do they respond to things like imatinib, which we use in other malignancies such as GISTs with c-KIT mutations? The data is quite poor at the moment. We haven't got enough data to know for sure whether actually giving mucosal melanoma patients c-KIT inhibitors actually gives us a benefit. We have given patients either privately or on compassionate grounds imatinib, largely because it's relatively low cost, and so the feeling is that actually we can try it in some patients, but I haven't seen overwhelming benefits from it, and understanding what the dose that maximizes our response in imatinib isn't really there yet. So we need more data about mucosal melanoma. With regards to its response to immunotherapy, it seems to be sitting in the middle between a cutaneous melanoma and an uveal melanoma. So it sits nicely in the middle, and generally speaking has a less good response than cutaneous, but a better response than uveal melanoma. So about a 20 to 30% response rate. So generally speaking, we would say if the patient is well enough, we would consider using combination immunotherapy in these patients, and we would expect anywhere between 20 and 30% of them to respond. So not brilliant, but not as bad as the responses we see in uveal melanoma, which we'll go on to talk about now. Uveal melanoma is a completely different kettle of fish in terms of its etiology, but also mostly in terms of its response to treatment. And we'll talk a little bit more about why in just a second. So just as a summary, these are the drug therapies that we could theoretically think about using in our different melanoma groups. And in reality, not all of these are licensed, but these have all got sort of constant sort of potential, and we may see them coming along. You'll note here that there's NRAS mutations in cutaneous melanoma. There have been a number of clinical trials looking at NRAS blockade and seeing if there's a response in cutaneous melanoma. As yet, we've not seen any enduring response from the agents that have been trialled, but there are ongoing NRAS trials to try and see if we can get traction in it with another group of patients. And generally speaking, BRAF and NRAS are mutually exclusive, so patients generally don't harbour both, which potentially opens up another group that we could theoretically have a treatment option for if we find an agent that is effective. So just to talk about uveal melanoma just for a short period of time. So it is the most common adult ocular malignancy. It's about 6 per million of the population, and generally speaking can affect any of these parts of the eye, the iris, the ciliary body, or the choroid. The primary is partly of the concern, but mostly our big problem comes with uveal melanoma when it becomes metastatic. So about 50% of all uveal melanomas will metastasize, and when they metastasize, about 80% of them metastasize to the liver, with other or additional metastases seen in the other remaining 20%. The big problem we have still ongoing in uveal melanoma is that we don't have any proven effective therapies. There's still no real standard of care, and I'll talk about how we approach a patient with a metastatic uveal melanoma in just a moment. We are optimistic. So Liverpool's one of the uveal melanoma centres in the UK, as interestingly as Mount Vernon, where Dr. Shaw works. So we are continuously trying to run clinical trials to try and understand how we might get more traction in uveal melanoma. So it has an incidence of around 6 to 10 per million in Caucasians, and much rarer in other races. It's associated with fair skin, light eye colour, and increased latitude, much like cutaneous melanoma. The etiology remains unclear. It doesn't appear to be related to sunlight exposure, but it's interesting that it is seen in the same population. There are a number of different mutations, but it is, and there is an association if people do have nevi, but it's a very low rate of transformation, and trying to understand and genotype these patients hasn't become standard of care in any way yet. But trying to understand those that are more risk is a big piece of work that's ongoing. Normally, these patients will present via their optician. They will go either with visual disturbance, or they'll go for a regular annual or 2-yearly eye exam, and it will be picked up by their ophthalmologist, optometrist. It's really interesting. That's normally the route that they'll come through. They'll have just gone expecting to get a new pair of glasses and end up being referred into to uveal melanoma services. So treatment of the primary disease is successful in the majority of cases, although relapse may require salvage therapy. Relapse does happen, and we do monitor patients with our ocular surgical colleagues to monitor and then manage any relapse that we see. We can preserve sight in some patients if the tumour is identified early, but quite often patients will lose the sight, and often the presence of their eye. So surgical approaches using enucleation and endoresection. You can use radiotherapy, either plaque radiotherapy or proton beam radiotherapy, which we deliver here in Liverpool. You can use external beam, although we most commonly don't. We use one of the other two. And you can use phototherapy. Orbital radiotherapy can be offered when there's extraorbital extension, so we can give adjuvant treatment essentially in the form of radiotherapy. And we always give treatment within super specialised units. So Moorfields, Liverpool, Sheffield and Glasgow are the units where uveal melanoma is treated, and where the ocular surgeons and ophthalmologists are really experienced in managing this. So we work really closely with St Paul's ophthalmology unit here in Liverpool. So then, how do we predict whether patients get metastasis? Can we predict if patients get metastasis? So the answer is we can, we think. There was a Liverpool-derived predicted cytogenetic score that we put together, which looks at both the genetic abnormalities and also the histopathological features, and together generates a prognostic score. We think about 50% of cases metastasize, so it's a hugely metastatic potential disease. The median time between diagnosis of primary disease and metastatic disease is around 3 years, but ranges from concurrent all the way to 30+ years. And I saw a gentleman just this week who's been 11 years since his primary, and he's presented with multiple liver metastases less than a year after his most recent screening MRI. So they can happen a long time post-treatment, and they can happen very quickly. As I said, liver is the first site of metastases in between 80 and 90% of patients. However, the first site of metastases can be somewhere else: skin, lung, bone. If I'm honest, the majority of people who get those metastases often present with liver metastases as well. As it progresses, it doesn't stay liver only over the longer term, and you know that the disease is picking up pace and changing tempo if it metastasizes elsewhere. You can get brain mets from uveal melanoma. It's very rare. So with cutaneous patients, at the beginning, before we start treatment with any form of palliative treatment, we now include an MRI of the head, because actually brain metastases from cutaneous melanoma are very common. Brain metastases from uveal melanoma, ironically, are much less common. Local recurrence, yes, brain metastases can happen, but very, very late on in the process of the disease. And the big issue with them is they have incredibly poor prognoses. So historically, the survival from diagnosis of symptomatic metastatic disease was on average between 3 and 6 months. And in reality, the prognosis from asymptomatic disease is not that much better, somewhere between 6 and 12 months. So actually, the big challenge is a lot of these metastasize, and then when they metastasize, they have a very poor prognosis. So when we think back to that score that we use loss of chromosome 3, M3, is a strong predictor of poor outcome. And we often use that to to prognosticate our patients. And we also look at polysome of chromosome 8, the cell type we can see, the tumour location, and whether it's got various different other histopathological features such as vascular involvement. Interestingly, if the decision is made to make the diagnosis on imaging and to go for a local eye preserving treatment in the primary, we don't always have tissue. So some patients will be very difficult to prognosticate because you just don't have tissue to do that, in which case we normally will err on the side of caution, and actually we undertake active surveillance in those patients more often than not. And you can see that actually the genetic changes do have a significant impact in terms of whether patients are going to metastasize or not, and that ultimately drives the difference in prognosis. And you can see monosomy 3 here, they do very badly if they've got that change. So the liver can remain the only site of disease for a significant period of time, sometimes many years. So quite often you will give local treatment, so that normally in the form of surgery, IFA ablation, or increasingly chemo or radioembolization. So we use multiple different technologies to manage the local disease. They only really are effective in patients that get oligometastatic disease to the liver, where you can either isolate a lobe of the liver, or you can manage 1 or 2 metastases as individual entities. We have used a number of different local therapies, chemoradioembolization, but also isolated hepatic perfusion with methylene, something called DelCath, which is pictured here. So we have run this provision here in Liverpool. They also run it most commonly in Southampton. There have been quite a number of trials, so we're looking at whether we can actually deliver DelCath in a more standardized fashion, so that we can set it up potentially as an NHS treatment for people who've got liver-only disease. It's still in setup. We are probably a year or 2 away from actually achieving that in reality, and we have to talk about funding, but there's some recent data that suggests actually they do get significant improvement in overall survival if we undertake DelCath. So at the moment it's a relatively small number of people, but it may well increase to some degree in the relatively near future. And because these patients are essentially clustered in specialist centres, it helps us to be able to get these therapies up and running, because they're relatively high involvement but a small number of centres. We have tried lots of other drugs. So there's a theory that MEK inhibition might well work in uveal melanoma. And actually we did run some trials looking at whether selumetinib was actually helpful in metastatic uveal melanoma. We get an improvement of progression-free survival, but there isn't a statistical improvement of overall survival, as you can see, 11 versus 9 months with selumetinib. So again, it's whether how that progression-free survival impacts on overall survival, and whether progression-free survival actually impacts on symptomatology and patient quality of life. So there's lots of things to weigh up, but it's ultimately not led to selumetinib being licensed in uveal melanoma. So that brings us around to immunotherapy. Essentially, we have seen very disappointing results compared to cutaneous melanoma, and I'll talk you through a little bit why we think that is in a moment. Essentially, we see very poor response rates to single-agent monotherapy immunotherapy. So anti-PD-1 agents, pembrolizumab, has a response rate of around 3%. Anti-CTLA-4 is a bit better, around 7 to 8%, we think. When we use combination ipi-nivo, it's very broadly reported. There are some older studies that suggest that there's a response rate in around 8 to 10% on combination. There's some more recent data that would suggest it's somewhere between 10 and 15%. So if we look at sort of the response rate compared to what we see in cutaneous melanoma, it's a very, very different scene. But unfortunately, although the response rate is different, the toxicity implementation is exactly the same. So we have patients with uveal melanoma who experience very significant toxicity, but at a much lower likelihood of getting a benefit. So it's a very complex patient population. It's a very complex conversation. And there probably is a subgroup within uveal melanoma patients who are going to respond to these patients, and it's whether we can actually do more stratification within the NHS care that is really starting to sort of be raised amongst the community. Can we actually identify patients more effectively who might respond to immunotherapy? So there are lots of elements that respond to sort of contribute as to whether somebody responds to immunotherapy and whether a tumour responds to immunotherapy. And there are some that are tumour cell intrinsic, some that are tumour microenvironment intrinsic, and some that are systemic. So there's things like PD-L1 expression and mutational load. There's also things like T-cell infiltration, T-cell activation, how good is your immune system, how present is it in the tumour, and also how good is the delivery of T-cells into tumour by the peripheral blood circulation. And also, is there differentiation in terms of T-cell activation and antigen presentation, and do different HLA subtypes actually respond to immunotherapy better? These are the questions that we have at the moment. When we look at tumour mutational burden, we know and think that tumour mutational burden is a real marker of whether a patient's going to respond to immunotherapy. Actually, the more gnarly and foreign and abnormal a tumour looks, the more likely they are to get a T-cell that recognises that antigen as an abnormal antigen and thus end up in a T-cell response. You can see melanoma is really high on this graph and uveal melanoma is right down the bottom. So actually, the immunogenicity of uveal melanomas is very, very different to the immunogenicity of a cutaneous melanoma, which is probably in part the reason we don't get such a good response. Other things we think about are actually how many T cells, how many tumour infiltration lymphocytes, how many TILs are actually present in a tumour. And you can see that there are different degrees. So some tumours are immune deserts, some are immune excluded, by which we mean the T cells know the tumour's there, but they tend to sit around the outside and aren't able to infiltrate internally. And then there's the group that are inflamed and actually get really good T cell penetration. Cutaneous melanomas are inflamed, and uveal melanomas are normally immune deserts, sometimes immune excluded. So the actual potential of the T cells to get in and do anything is very limited. And also the PD-1, PD-L1 expression, as you can see, is very different. So the top here is uveal melanoma. There are some T cells present, not many. There's no PD-L1 expression, no PD-1 expression. If you can compare that cutaneous melanoma, completely different, with lots and lots of expression of T cells, but also their exhaustion markers, which we reverse with our checkpoint inhibitors. So you can see that actually, if you understand how many CD8 T cells are in the tumour, what their PD-1 expression looks like, and how mutated that tumour is, you might be able to actually find subgroups that will respond better to immunotherapy. But we aren't doing that at the moment. That is something that's very much for the future. I'm conscious of time, so I'm going to whistle through the last couple of slides. But essentially, this is the question: should we be offering immunotherapy as standard of care for uveal melanoma? Well, essentially, it's an important discussion to have with the patient. It is not a one-size-fits-all. There are some patients who present with relatively small amounts of metastatic disease, and you would definitely think about oligometastatic control and localized therapies. There are some patients that present with very miliary disease, with very rapidly progressing cancer. The question is actually, are you going to get an immune response there or not? And then there are the patients that sit between those two options, and actually there is really lack of clarity about how we should treat them. So at the moment, we're having very honest conversations with patients about the potential for side effects versus the potential of response, and actually having very much two-way open conversations about whether immunotherapy is the right thing to try or not. But they do hold a 10 to 15% chance of response, which is not completely non-existent. So it is a discussion. The last thing that at the moment is sort of taking the world by storm in uveal melanoma, obviously it's a small world, so the storm's quite little, but there is this concept of using T-cell bispecifics, which essentially is a molecule which on one end binds to a protein within uveal melanoma tissue, IMCGP100, and on the other end binds to CD8 T cells. And what you find is essentially the concept is that the bispecific binds the T cells and drags the T cells into tumour. So it's sort of the oncology equivalent of taking your horse to water. It's actually pulling the T cells into the tumour in the hope that there's enough immunogenicity once it's there to trigger an immune response. And interesting, what we're seeing is responses for the first time. So we're seeing patients that have got reduction in disease, but most importantly, actually, they're stabilising their cancer. We don't see massive complete responses. We don't see many partial responses, but we do see stable disease for a significant length of time, much longer than we were seeing with any of our treatments to date. So it's interesting. It doesn't seem to shrink down malignancy. It just seems to manage to control it. This is only effective in patients with a HLA-A201, A2 A0201 HLA subtype. So we have to subtype patients before they're potentially eligible for it. But this is going through the process of licensing at the moment, and there will hopefully be a compassionate use scheme open in 2 or 3 of our national centres in the late autumn, early winter time. So patients potentially are going to be able to get access to this if they have the HLA A2 subtype that's available. So we're looking at a position where patients potentially are going to have access to immunotherapy, access to this drug, which is called tebentafusp. It runs off the tongue, and also we always like to try and enroll patients in clinical trials, and there are certain clinical trials that are starting to recognise that uveal melanoma is an unmet need, and so there are a number of different approaches that are actually opening uveal melanoma cohorts. So although we still don't have a standard of care that has really good traction and efficacy, we are getting to the point where we hopefully will have more options for uveal melanoma, but it's unlikely to be checkpoint inhibitors on their own. And then I just want to spend a slide on Merkel cell carcinoma. So Merkel cell is a really interesting skin malignancy. It's a neuroendocrine cancer of the skin. It normally presents as a single skin nodule in the first instance, and we normally treat it with surgical resection. It can be very aggressive, it can be locally advanced or metastatic very commonly and actually very quickly, and they normally present in extremis with really significant disease. Interestingly, it's very radiosensitive and it does respond to immunotherapy. So we do, and it can respond to chemotherapy as well. So we tend to treat it like a small cell. So they have avelumab metastatically in the first line, and if they progress, then we can treat them with carboplatin and etoposide chemotherapy, both of which are used. We tend to favour immunotherapy first line. If you've got a patient that's not fit for systemic therapy, then we do often think about radiotherapy. So in summary, highly curable if found early. Metastatic SCC needs more research, but we're getting there and we're getting some good responses. Metastatic melanoma is getting better, but we've still got a long way to come, particularly in uveal melanoma. And if we can prevent it, that is better than needing oncological treatment, obviously. In terms of going back to how do we decide between dab-tram and encobini, it's interesting. So both combinations used for BRAF mutated cutaneous disease in cutaneous melanoma. Most people historically would have chosen to give dabrafenib and trametinib. The data, there isn't so much to really call between it. It's very similar. The side effect profile though is slightly different. So dabrafenib and trametinib, the major side effect is that they cause fevers. Encobini can cause fevers, but it causes a much less incidence. But the thing that encobini generally causes can cause cardiac impairment and also can cause visual impairment. So it depends a little bit on your patient and also on your centre. There was quite a big shift to using more encobini during the COVID time because of the fact that the patients were less likely to experience fever, thus less likely to go into hospital with fevers and concerns about catching COVID. But normally a centre will have an inherent desire to go with one or the other. Patients that have had significant toxicity in the adjuvant setting from dab-tram and have progressed on immunotherapy may actually do better on encobini. So you have that option to use it if you've used dab-tram in the adjuvant setting and had some problems with toxicity. So it depends a little bit about side effect profile and also previous toleration is how we would decide. And certainly some centres have gone to using encobini as their standard, others have remained with dab-tram. There was also a dab-tram production problem and limitation relatively recently, so some centres chose to go over to encobini and have stayed there. So it's quite a personal choice, but those are the main decisions, whether you've got likelihood of fevers or not, essentially. Please do keep putting any questions in the chat. In the meantime, we're going to move to our 3 case discussions. So I'm going to invite Dr. James Parry to present his case about metastatic malignant melanoma, and we will go from there.
So, evening, my name is Jim Parry. I'm one of the medical oncology trainees from Clatterbridge in Liverpool, and I've got a case discussion that came to Dr. Sacco's clinic. So, sorry that's a bit smaller as I expected, but it's a referral letter. So I'd appreciate if you could see this gentleman, a 50-year-old gentleman who's usually fit and well, who I performed a left neck dissection on for metastatic malignant melanoma of what was thought to be an unknown primary. However, subsequent amputation of the top of his left ear we found that the primary is likely to have been on the left ear. The lesion on the left ear was a 0.1 millimeter Breslow thickness without ulceration, and 1 out of 30 lymph nodes were positive for malignancy from the neck dissection. There was no evidence of extracapsular spread. BRAF results pending. This was discussed at MDT in your presence, and the consensus was that we should offer adjuvant therapy, essentially. So there's a few bits in there that we've not done much about staging, but the AGCC8, you need all of those bits to work out the staging. So the relevant bits that I think from the letter are that he's 50-year-old, fit and well, so a young guy, 0.1 millimeter Breslow thickness, no ulceration, 1 lymph node, no extracapsular spread. So in terms of thinking about staging, so 0.1 millimeter with no ulceration makes it a T1A stage. 1 out of 30 lymph nodes makes it N1B, and putting those together makes it stage 3B overall. And as mentioned in the letter, when he came to clinic, his BRAF status was pending still. Okay, so yeah, sorry, a bit more summary. So he's just 3B malignant melanoma with BRAF pending. He had a PET scan performed which showed no metastatic disease. He was fit and well, as the letter stated, with a performance status of 1, and fairly minimal past medical history, just some PE for which he was on DOAC and hypertension. And this was a fit and well gentleman who was motivated to have treatment and very eager to have some adjuvant treatment. So we decided to start him on some adjuvant immunotherapy. He had adjuvant pembrolizumab. Because his fairly non-typical presentation where he had his neck dissection prior to his surgery on his primary, his scans weren't particularly up to date. So the baseline scan that was done just after he'd started treatment, I think there was something in his iliac blade and that was suspicious for a metastasis and some subcutaneous metastases that were just suspicious on that early scan. But unfortunately, on his next scans, after 2 cycles of adjuvant pembrolizumab, there was confirmed disease progression in those areas. At this point, we had his BRAF status and it confirmed that he was BRAF mutant. So after quite a lot of discussion between the team and with the patient, we decided to switch him to combination immunotherapy, so ipilimumab and nivolumab for treatment of his, so this is now first-line treatment of his metastatic disease. He also had a single fraction of radiotherapy to his iliac neck, which was a bit symptomatic. So now he's on combination immunotherapy. Unfortunately, after 1 cycle of his combination immunotherapy, he had a grade 3 colitis. He also had a grade 1 hepatitis. Didn't settle with steroids, so he required infliximab for his colitis, but that did do the trick, and his symptoms resolved. He then had a normal sigmoid biopsy, so after further discussion between the team and the patient, we decided to restart single agent nivolumab. And then he had a little bit more radiotherapy, this time to his humerus, which was symptomatic as well. So that was him really. So in terms of the discussion points for this case, it was quite complex, but these do sometimes come up where the staging isn't quite straightforward and results don't come in the expected order. He was quite unlucky that he had progressive disease early on in his adjuvant treatment, which led to an interesting discussion about the decision to switch to combination immunotherapy at that point, because we would have had the option to start BRAF targeted therapy. He's a gentleman who had significant toxicity early on in his metastatic treatment, which is not uncommon. And as we heard earlier on, a lot of patients don't get through the 4 cycles of combination immunotherapy. So that led to, again, another lengthy discussions, and at that point, the decision to switch to single agent immunotherapy. And that does leave the option that we have the option for targeted therapy if he progresses on immunotherapy now. So that does leave that option open. He is currently doing well on a single agent with no further toxicities, and is awaiting his first scans on that to see whether we've got any disease control or response. And the other point that I thought was interesting to remember is the use of other adjunct therapies, so radiotherapy for symptomatic treatment, which can be quite helpful, and was for this gentleman. And that was my case. Thank you very much for listening.
I think it's interesting, isn't it, about how you broach that conversation when patients started on adjuvant treatment and then progressed. I don't know how your experience of it is. Do you find it's something they're expecting? Do you find you warn them at the point of adjuvant treatment that that's a possibility?
So I think for this, I think you do warn them that it's a possibility, but I'm not sure how much they take that in, especially depending on what they've been told prior to coming to the clinic by surgical teams and things, that this is just to make sure you don't have any further problems with your cancer and things like that. So, and I'm not sure how well we manage those expectations. I think we probably go along with that a bit as well in our limited time in consultation. So I think this gentleman was shocked that he progressed in adjuvant therapy, and that's always been my experience, that people are shocked that they progressed through adjuvant therapy. And then it was, quite long discussions about what the next approach was, and in the end we've kind of gone down the immunotherapy route, with obviously you then got bad toxicities, which was unfortunate for him. Yeah,
I think it's always difficult, isn't it, about the toxicity angle, and particularly if they get toxicity in the adjuvant setting, then what you do in the palliative setting is quite difficult to navigate. And also I think when we're deciding between adjuvant treatments, either targeted agents or immunotherapy, I think toxicity is a really big consideration, but not great in either category. And certainly we always used to, if they had a BRAF mutation, we would give them dab-tram in the adjuvant setting, and if not, then we'd give them immunotherapy. But the toxicity of dabrafenib and trametinib appears to be quite high in the adjuvant setting, so you end up with immunotherapy, and then what do? Do you give more immunotherapy, and where do we go with there? So it's a bit of an interesting thing since we've had adjuvant, I think, to navigate the transition from adjuvant into palliative.
Jim, when he first progressed, was it just oligometastatic disease, or was it in different places? Didn't catch that.
No, sorry, he had several areas of bony metastatic disease and also some subcutaneous mets that were progressing as well. So it's
okay. I mean, my thought was, and it's really a question to Anna, is if it was kind of oligometastatic disease, particularly with these melanomas, have you ever referred on to the kind of the SABRE team and stuff? Consideration of
So we do. It's a really important question. I think there's two elements to that. One is about whether we treat oligometastatic disease locally, like as we would do in the uveal, and we definitely do if they've got small volume disease. It's always that question of, do we treat it locally and keep our systemic therapies in reserve or not? And there is not a consensus, and there's not much data to navigate, as different clinicians will feel differently about it. But also the importance of knowing about brain metastases. So important for all patients, but particularly the data in metastatic disease for brain mets is that actually single agent immunotherapy doesn't really have an efficacy in brain metastases, but dual agent combination therapy has about a 50% response rate, interestingly, probably because you're priming the T cells in the non-peripheral, more secondary lymphoid tissue that are then crossing the blood-brain barrier and getting into the brain metastases. So it's really important for us to know about whether they've got brain mets. And then the question is, do we give systemic therapy, or do we give SRS, or actually both? And again, the jury is out, but it is important to know the distribution, because it does guide your therapy a little bit. And we also use things like ECT and external beam radiotherapy at points as well. Great, thank you very much, Jim. That was really, really great. Ian, can I move over to you and you present your case? Is that all right?
Hey, my case is on Merkel cell carcinoma, and we're discussing palliative radiotherapy. And it kind of leads on from Anna's last point from her slide about Merkel cell carcinoma, in that if patients are particularly poorly, or they've got poor performance status, we're not consider palliative radiotherapy as opposed to systemic therapies, which is what this case discussion is about. As I was saying, so the Merkel cell carcinoma is a rare, aggressive neuroendocrine skin malignancy with a propensity for local, regional, and distal occurrence. And the main form of treatment is surgical, but Merkel cell is considered radiosensitive. Usually we want to get surgical excision margins of at least 2 to 5 centimeters, kind of wide margins, and we roughly look for kind of like similar margins when we're applying it for radiotherapy. As well, you have a large margins for that. So primary radiotherapy can be considered as an alternative depending on clinical situation, needing tissue preservation, functional status of patient, particularly if there are aggressive features of Merkel's together with risks of local regional recurrence. It's likely, and it's likely radiosensitivity that's led to recommendations for adjuvant radiotherapy to the primary and nodal patient after resection. And that's particularly those high-risk features there, large tumours, unresectable, close or positive margins, and a sentinel node involvement. So just briefly in terms of what we do with for the radiotherapy, so we spoke about definition of the planning target volume of 2 to 5 centimetres circumferentially and a minimum of 1 centimetre deep margin. Doses that we use, we can use 50 to 55 gray in 20 to 25 fractions, but we can use up to 60 and 30 to the primary. For our more elderly, frail population, bringing them in for 3, 4, 5 weeks is often impractical and very troublesome. So you tend to use more hyperfractionated courses, and we can find doses of 20 gray and 5 fractions, 30 and 10 have been reported to potentially eradicate low volume disease in patients with poor performance status, but the evidence is a bit sketchy at best. And our case today is really that real world application of this. Okay, we have a 90-year-old lady that has a performance status of 2 with previous thrombocytosis. She was diagnosed with a Merkel cell on her left lower leg, and she had multiple nodules on anterior and posterior sites. She had a CT scan in March which showed no lymphadenopathy or distal mets. So she was discussed in the skin MDT, and they felt that systemic treatment wasn't an option for her, and given the multiple lesions, location, her age and performance status, that certainly wouldn't be an option. So it was for consideration of palliative radiotherapy by the skin oncologist that was in the MDT. But he was then away, so it came to our team for the skin oncology team. So we kind of reviewed the case, and given the multiple locations and the need to treat the whole lower leg and the risk of ulceration and other side effects from that, we felt that best supportive care would probably be in this patient's best interest. But because it had already been mentioned to her, she still would like a second opinion from the original oncologist at the MDT. So she saw that second oncologist, and they discussed the benefits and side effects and offered palliative radiotherapy. They showed the 20 gray and 5 fractions and completed it in April. Just very briefly in terms of how she was treated. She was treated with anterior posterior fields. She had a 5mm bolus all the way around the lower leg, and she was scanned with the bolus on. And then I got some pictures coming up now, and then she kind of had an Orfix cast around it to kind of keep it all in place. So you can see here from the images kind of like the extent, this is on the anterior aspect, just kind of where these different points were. So it's kind of extending up and down the whole leg, and it was kind of equivalent on the back as well, and a few on the sides. And then on the picture on the right, you can see the bolus that we used to wrap around there as well. And the reason that we're using the bolus is to make sure that we're getting adequate skin dose, and that's all to do with the photons in terms of their dose distribution at the skin. So this is just briefly in terms of planning, kind of what you can visually see where we outlined where we were treating for her, and you can see we kind of the bolus wrapped all the way around. Okay. So interestingly, for this case, we used an anterior and posterior field, but usually when we're treating the extremities, particularly the lower leg, we like to try and have like a lymphatic corridor to try and help prevent some of the side effects, particularly kind of leg edema and blood and vascular supply. In this case, I think it was felt because all the lesions were circumferentially all the way around, it was decided to treat the whole width and not leave a vascular corridor, which kind of comes back later to potential side effects. So this is kind of, again, just dose distribution in terms of how you can see how it was treated. Again, just a dose distribution across the whole of the leg, covering the 20 gray dose. Again, that's just a horizontal profile. So in terms of how she did, so 6 weeks post radiotherapy, so this was a review at the end of May, she had a mild grade 1 skin reaction. Most of the small lesions disappeared, and the largest lesion remained present, but it decreased in size. It was noted that she had some previous swelling of the left leg prior to the radiotherapy, which she reported to the oncologist had improved slightly. Then I spoke to her last week and to find out how she was doing. So she's now reported that the leg is more swollen than what it was pre-radiotherapy. The skin is a lot harder, her knee is kind of swollen up quite a lot and it's very painful since the radiotherapy. The lesions are, most of them are roughly the same size, some are slightly smaller, some are slightly bigger. There is no apparent evidence of ulceration, but she is now having a lot more difficulty walking and affecting her quality of life to an extent. So really the learning point for this is, so stretching on to where when Anna was saying that you can give palliative radiotherapy for Merkel cells and it is very, very, very sensitive. Yes, you can, but obviously it's also balanced in terms of the kind of the functional status of the patient and that balance of obviously trying to control the Merkel cell versus kind of the side effects that you're potentially going to give the patient. So that's kind of like really the learning point from this. I think on looking at this case again now, I still think I would probably lean more towards kind of a best supportive care picture, because although that she has had some degree of disease control with this, it is now starting to cause some significant toxicities with it. So, and I imagine that will probably only get worse over time. So yeah, that's my case.
Thank you, Ian. That was really, really interesting. And I think you raise a really valid point that has been sort of the flavour throughout this, is that we can get good responses, but it is often at the cost of toxicity. And I think it's so important to have that MDT approach and make sure that we're working alongside yourselves as clinical oncologists and our surgical colleagues to make sure that we balance those things as much as possible. And I think this case really illustrates that. So thank you very much.
Yeah.
I think with that in mind, we'll move on to our last case presentation that focuses again a little bit on that balance between treatment and toxicity. So I'm going to hand over to my colleague, Dr. Laura Cossar, to give us our last presentation.
I just want to say thank you to Anna for providing this case as well. And again, this, as Anna referenced to, this is going to be a case more focusing on terms of the toxicity in terms of adverse immune-related effects. There's a 60-year-old gentleman presented with metastatic melanoma, and starting on anti-PD-1, nivolumab, and anti-CTLA-4 ipilimumab combination therapy. At baseline, he had normal cardiac markers, so troponin T and pro-BNP, and after 2 cycles of treatment, presented with fatigue and mild ankle swelling. On clinical examination, this gentleman had pedal edema. He had an ECG performed at that time, which showed regular ectopics and the right femoral branch spot. And a repeat of his troponin and pro-BNP levels at that time demonstrated a significant elevation. So I'm not going to pretend to be an expert on cardiac MRI findings, but cardiac MRI is our modality of choice for investigating such patients with suspected immune-related myocarditis. Panel A there, with some helpful arrows, shows us some areas of hyperintensity on the T2 image, demonstrating edema around the ventricle, and panels B, C, and D demonstrating some early and late gadolinium enhancements, which are concentrically showing some areas of fibrosis around the left ventricle there. So these findings are fairly definitive that this patient does have immune-related myocarditis, as would be suggested by the elevated cardiac markers. And so I guess asking the question, is this a fairly typical presentation in this scenario? This is a study, a cancer registry study from the United States, which identified 35 cases of clinical myocarditis associated with immunotherapy. The median onset time of presentation was 34 days. As can be seen, some patients do actually present very early within the first few weeks of treatment, and there are some patients that are presenting after many months of treatment. The right side of this figure demonstrates the baseline investigations at the time of presentation, and you can see the vast majority of patients when presenting with myocarditis have an abnormal ECG and an elevated troponin. It looks like about 50% of patients have maybe what would be considered an abnormal left ventricular ejection fraction of less than 50%. And certainly about 2/3 of patients also have an elevated pro-BNP associated with the clinical picture. So this gentleman was treated according to our immunotherapy myocarditis guidelines and treated with 2 mg/kg of IV methylprednisolone for 5 days. This gave a rapid biochemical improvement, and so he was switched as per our protocol to oral prednisolone of 1 mg/kg. Day 2, repeat troponin T and pro-BNP unfortunately showed a significant elevation again to quite high levels. And obviously this prompted a change in therapy, given that it had a significant reflare of myocarditis following the switch to oral steroids. He required higher dose IV methylprednisolone and was treated with 1 gram of IV methylpred for 5 days, and then went to a relatively high dose of 4 mg/kg for a further 7 days. To then facilitate his wean onto lower doses of steroids, alternative immunosuppressant agents were used. So he was given T-cell directed therapy with tacrolimus, and also received 2 cycles of infliximab cytokine-directed therapy. Fortunately, this approach enabled him to have a wean off steroids, but he continues on tacrolimus therapy. Fortunately, his cardiac function has now normalised. His parameters in terms of his troponin T and pro-BNP are near normal, and he has had an excellent partial response to the therapy for the 2 cycles of combination immunotherapy that he received. So I guess this case, as Anna suggested, is there to highlight and acknowledge the significant number of immune-related adverse events that we are seeing given the immunotherapy for skin cancers. I feel that immunotherapy myocarditis is certainly something that we're having increasing recognition of locally in our practice. The Mahmood study that I referred to earlier seemed to indicate that about 1.14% of patients on either combination or single agent immunotherapy were seen as developing myocarditis. I think it'd be quite interesting potentially to chat with Anna about what our local data, so real world data is showing on that, because we are increasingly looking for this. But given the amount of patients we're now treating with these immunotherapy agents, it is something that is not going to be infrequent in clinical practice. In terms of the speed of onset, as you can see there, a median onset of 34 days, about 81% of patients present within the first 3 months of treatment. So this is something that is majority of patients are developing early in their treatment. I think some learning points, particularly from this case, is that myocarditis can present quite insidiously, and fatigue can certainly be one of the major features. So certainly cardiac markers are now incorporated in our fatigue screen for patients receiving immunotherapy, and that is picking up some cases of myocarditis where fatigue is really the only presenting symptom. Another learning point from this case is that rapid reflare can occur on steroid weaning, and therefore careful monitoring these patients really is essential to make sure that they are being safely brought down on steroid doses, and just really highlighting the importance of our immunotherapy teams in monitoring and supporting these patients and acting swiftly if a reflare does occur. And also, I think is becoming much, a universal thing with all the itises we're seeing with these drugs, is that the help and support from the associated medical practitioners is really key in terms of our cardiologists helping us with these patients, and developing those relationships really gives the best care for these patients.
Fantastic. Thank you very much, Laura. That was really, really good. And yes, I am most definitely keen to show the sort of the toxicity side of things, but also the management of it. So, so I'm really grateful for you presenting that case. In terms of our sort of local, so we've been quite focused locally in Liverpool on looking at toxicities, particularly rare and unusual toxicities. So we did a series of baseline assessments, and we actually do baseline assessments on most of our patients treated with immunotherapy now. And we see a sort of anywhere between a 4 and 5% incidence of myocarditis to some degree, which is quite high compared to the sort of the annotated incidence. And so certainly we're looking to do more work both locally and nationally to try and understand myocarditis a bit more, so that we can hopefully optimise management and so these patients don't get these reflares, because we certainly do see them at the moment. Great, thank you so much for presenting. So that leads us to the end of the webinar. I'm going to do my best to share our final slides. So just to say, there is a certificate that will be sent out, a certificate of attendance on completion of the feedback, so please do feed it back, and Dan's put it in the chat as well. There is an ACP problem solving in oncology webinar series. The next one will be later in the autumn. Also, there's an ACP Trainings Weekend this year planned from the 15th to the 17th of October in Bristol. Registration and accommodation is free to all ACP training members. Please do come along. We've got a great looking schedule, and it's a really good weekend, and really nice to network after so many months of not being able to do that. And you can register for that at theacp.org.uk, as it says there. So on behalf of the speakers and myself and everyone at the ACP, thank you to everyone who attended, and good night.